So it's time to talk about inserting a peripheral IV cannula. The objective of ordered therapy is going to be hydration, IV drug administration, the administration of blood or blood components, or to establish a preoperative IV line. Characteristics of available veins that we need to be looking at is what size is the vein, which way does that vein run, is the vein soft or is it hard and cord-like. The vessel that you select should feel soft and spongy. There's different ways to help select a site. You can use visualization technology, such as a vein light or ultrasound to help identify a vein. For adult patients, veins that should be considered are those that are found on the dorsal and ventral surfaces of the upper extremity. You're looking at the metacarpal, the cephalic, the basilic, the median veins, but again, try to avoid the lateral surface of the wrist approximately 4 to 5 inches because of the potential risk for nerve damage. For pediatric patients, you're going to look at similar veins in the hand, the forearm, the antecubital area, the upper arm below the axilla, veins in their scalp, foot, and fingers if they're infants or toddlers. Avoid the ventral surface of the wrist because of pain and possible nerve damage to the radial nerve. And you need to also avoid veins in the right arm of infants and children that have congenital cardiac defects because they have some decreased blood flow to the subclavian artery after procedures that help treat that defect. So site selection should be initiated routinely in the distal areas of upper extremities. Subsequent cannulation will then be made proximal to the previously cannulated site. So you can always go above, but you should never go below a previous IV site. Sites are preferable in the non-dominant arm, and you should avoid hard sclerosed veins, the inner aspect of the wrist, an extremity that is affected by a CVA, areas where there's flexion whenever possible, an extremity that has been affected by a previous pertinent surgery, such as a mastectomy with axillary dissection. Avoid metacarpal veins of obvious arthritic hands, below areas of phlebitis or infiltration. You should avoid areas of ecchymosis. Avoid the dominant extremity whenever possible. Avoid lower extremities of adults unless absolutely necessary. Generally, lower extremity cannulation will require specific physician approval, and there is an increase of tissue damage, thrombophlebitis, and ulceration. Avoid previous cut-down sites or a hand or arm that has a patent graft or a shunt site for a dialysis. Avoid areas of pain where there's pain with palpation, areas of valves in the veins if you can visualize those. Areas of planned procedures should be avoided unless otherwise directed. An arm on the side of a breast surgery, again, that has the axillary node dissection. Areas of radiation therapy or arms that have lymphedema. So to prepare the site for cannulation, you should clip excessive hair. Don't shave it because shaving will create a potential for microabrasions, which increase the risk of infection. Cleanse the site using an antimicrobial agent. The specific agent that will be used will be determined by your facility. Use a vigorous back and forth motion, working from the center to the periphery in a diameter of 2 to 3 inches for at least 30 seconds. Povidone iodine can be used for cleansing But if you use that, make sure that you use a concentric circle working from the area that you plan to cannulate outward, and it has to remain on the skin for at least 2 minutes or longer to provide antiseptic properties. Make sure that you allow the site to dry naturally. Those patients that have an iodine allergy, you can use the 70% alcohol or a ChloraPrep. When you're using the over-the-needle catheter, make sure that you inspect the catheter or the needle and the catheter for possible defects. Always pull the skin taut to help stabilize the skin and prevent that phenomenon that is defined as a rolling vein. Many patients will tell you when you get ready to stick them, oh, my veins just roll terribly. Well, one of the things that I want to leave with you with IV therapy is there is no such thing as a vein that rolls. It is a vein that just does not have the right stabilization maintained on it during cannulization. So if it rolls, then you're not anchoring it appropriately. Insert the cannula at a 5 to 15 or a 10 to 30 degree angle. You're looking for a backflow of blood, which will indicate that you have a successful entry. You cautiously advance the entire device slightly into the vein, because you could reach that backflow without having the device completely in the vein itself. If you slightly lift the device as you advance, you kind of lift the vein and it decreases the risk of poking through the vein on the other side. Once you have inserted the entire device slightly into the vein, then you're going to advance the catheter into the vein. So you're holding the device securely with your non-dominant hand, and you cautiously thread that catheter into the vein. Sometimes you just use a finger, sometimes you use the other hand, etc. But you never re-advance a needle into a catheter once you have begun threading, because it can cause a catheter emboli. Those needles are very sharp and it can shear off some of that plastic catheter if you're not careful. When you remove the needle from the catheter, you need to apply digital pressure close to the catheter tip to help prevent it from bleeding everywhere. Initiate slow infusion of the fluid and make sure that the fluid is flowing freely, and watch for evidence of infiltration. If you're using a winged infusion set, these can be a little bit more tricky in that it's much easier to poke through the vein or to have infiltrations. The device that is pictured on your slide has an attached tubing to it. When you're using this type of device, it's necessary to prime the air from the tubing with a normal saline. You aseptically connect the adapter, connect it to the adapter of the administration set tubing. Open the roller clamp and allow that fluid to displace the air. You can also use a saline flush and flush it through that way. Again, make sure that you pull the skin taut. And once you get into the vein, you will initiate the infusion, observing for a free flow of the fluid and for signs of infiltration. When you're stabilizing the cannula, make sure that you do not encircle the entire extremity with tape, because it can act as a tourniquet if you do have an infiltration. Do not allow tape to cover the cannula or insertion site junction. You need to be able to visualize the insertion site when you're doing your assessments to make sure that there's no signs of infection. And look at the infusion nursing standards or practice, because it stipulates that sterile tape should be used underneath a site dressing. And if you use a single-use IV start kit, realize that everything in that start kit before you open it is sterile, and it does include tape. Local anesthesia should be considered based upon nursing assessment of the patient condition, the needs, the risks, and the benefits. The one thing to realize, though, with local anesthetics is it can cause vasoconstriction, so it may make it a little bit more difficult to access or cannulate the vein. The nurse must be competent in the administration of local anesthesia for venous access device placement and according to facility policy. Again, site preparation, make sure that you allow time to dry the chemical that you cleanse with, because a chemical burn can happen. Chlorhexidine solution is the preferred solution, but it is not recommended for infants under 2 months of age. You can also use iodine, which is usually your betadine preparation, your povidone iodine, or a 70% alcohol solution. Clip the excess hair using the single-use scissors or disposable head surgical clippers. Don't shave. Difficult vascular access requires a careful assessment of the various available sites and collaboration with other healthcare team members. Vascular distension can be obtained through tourniquets, by gravity positioning, by placing a warm, dry heat to the extremity that you intend to cannulate, having the patient do the hand pump, or lightly stroking a vein. Some people say you stroke downward. I've always been taught that you stroke upward. Using like the alcohol swab or your chlorhexidine helps that vein pop up. Make sure that you use non-sterile one-time use disposable gloves, and use the no-touch technique. So the insertion site should never be palpated after you cleanse the skin unless sterile gloves are worn, without having to re-cleanse the skin. Vascular access device stabilization devices can be a transparent semi-permeable membrane. It can be the transparent semi-permeable membrane with a biopatch, or it can be an IV that has an integrated stabilization feature. Might be sutures, and if sutures are used, if they become loose or they're no longer intact, those should be removed. The VAD stabilization should be used to preserve the integrity of the access device or minimize catheter movement at the hub and prevent catheter dislodgement and loss of access. They should not interfere with the assessment and monitoring of the insertion site, and they should never impede circulation. The devices are dependent on specific facility policy and availability. Make sure that you apply a label to the IV dressing, and this is the information that should be on that label. And then instruct your patient of different things that they need to be paying attention to. They also need to know that they should call for assistance if the dressing begins to feel wet, if they have pain in the site, if redness develops or swelling develops, or if blood begins to back up into the administration set tubing. Then document your procedure and also include these things. With the parenteral fluid, include the type of fluid, the amount of fluid, and how fast you're infusing the fluid. If you have included any additives in the parenteral fluid, you need to know the names or include and document the name of the drug and the dosage of the drug. And with the cannula, make sure that you include the type of cannula. Was it a Gelco? Was it an Insight catheter? What gauge was it and what length was it? With joint stabilization, it's really necessary to check the skin frequently to make sure that there's no skin breakdown, especially at the pressure point areas. And you need to document which device was used and document frequent removal for assessment and range of motion, much as you would if you were using restraints. With IV site protection, physical immobilization devices that will protect that site should not be routinely implemented, and they should be avoided whenever possible, especially limb restraints. Again, a frequent assessment of the skin and the site should be done when you do physically immobilize a patient. And again, realize that soft mittens are not considered a restraint, but may help protect your IV site with a confused or pediatric patient.